Assalamu alaikum. Welcome, students. Today we have one commonly faced topic in your clinical practice, and it is equally important in your exams also. So before starting my topic, I just want to remind you why my videos are important. The first thing is they are very concise and exam oriented. Second thing is it's a very interesting and simple presentation. So recalling and remembering the types of the fracture and related things is very easy for you. So please like, share, subscribe to my channel. So we'll start with the today's case. So we have one a clinical case today. So to start with the So we have 60-year-old female patient. She had fall due to slip from the standing height. So it's not a major injury, but she had this fall at home. She's 60-year-old female patient. So it's an osteoporotic patient. So after the injury, patient noticed pain in the arm and deformity and swelling around the arm. And when examination was done, there was abnormal mobility along the arm. So that indicated there is discontinuity in the humerus. So there is the humerus fracture. And on further clinical examination, there was wrist drop. So there is some nerve involved. So in the wrist drop, which nerve get affected? It's the radial nerve which get affected in wrist drop. So this is a classical case of osteoporotic female with a trivial fall sustaining injury to the arm resulting in fracture of the humerus along with the involvement of the radial nerve presenting as a wrist drop. So this is the common scenario we'll get when patient has humerus fracture. So here if you see the patient is unable to dorsiflex the hand. So dorsiflexion of the hand is a deficit here. So the hand is dropping down. So because of deficiency of the extensor. So this is a wrist drop. And if you see this pink color distribution is the sensory distribution. So there is loss of sensation. So this is radial nerve involvement resulting in wrist drop. So this is a common association and associated nerve injury following the humerus fracture. So by this introduction, it's clear now we are going to discuss radial humerus shaft fracture today. So for two things you need to remember anatomically wise. One is what is the extent of the shaft of the humerus? So shaft of the humerus start from the surgical neck. So above surgical neck, it is proximal humerus fracture. So below the surgical neck, we have shaft of the humerus till upper surface of supracondylar ridges or upper end of supracondylar ridge. So below this will be the supracondylar fracture and above this one will the proximal humerus fracture. So shaft of the humerus extend from surgical neck to the supracondylar ridges. And the second thing what you need to remember is the close vicinity of the radial nerve. Radial nerve is very close to the humerus. If you see, this is the humeral radial nerve coming from the brachial plexus. It goes into the posterior compartment of the arm and this is your radial groove. Here it is in very close relation with the humerus, humeral groove. So humeral groove, it's very close relation and then it comes out and through the interosseous membrane, it pierces the interosseous membrane and come and into the anterior anterior compartment of the arm. So in these two levels, at these two levels, this radial nerve is in close relation with the shaft of the humerus. So any fracture over this area or any fracture in this area result in damage to the radial nerve, resulting in radial nerve palsy or wrist to drop. And you need to know what are the muscles attached to the shaft of the radius, shaft of the shaft of the humerus. So we have this one is the deltoid muscle. Deltoid muscle is coming from the lateral aspect of the clavicle and acromioclavicular level and inserting into the deltoid tuberosity. Then we have pectoralis major muscles. Pectoralis major muscle is inserting around the medial aspect of the proximal humerus. Then we have the rotator cuff also coming and inserting over this area. So depending on the level of the fracture and the attachment of muscles, there will be displacement. So you just remember what are the muscles attached. The displacement is very extensive for you. It's not required as an undergraduate. So then this is a diagram which is describing the involvement of the radial nerve when there is a humerus fracture. So as I told, radial nerve is having two close relation. One is when it goes through the groove, radial groove. There is a humerus posteriorly. There is a groove for the radial nerve, so it's a radial groove. So any injury, it may displace the radial nerve inside the fracture, and patient will have injury to the radial nerve. Second thing is when it passes through the interosseous membrane and enters into the anterior aspect, it may get entangled into the fracture. So these are the lower third and the middle third. These two levels are very important where the patient can have humerus fracture along with development of the radial nerve palsy. So what are the associated injuries? So sometimes humerus fracture, no, it's following very major injury or the road traffic accident, they have either floating elbow. Floating elbow means fracture to the humerus here, radius and ulna here, or shoulder dislocation is also an association. So depending on the fracture pattern, it may be like simple transverse fracture. As you can see, only one fracture line which is horizontal. Other is we can have oblique fracture, and or we can have spiral, the fracture extending like this. Then we can have more than one fragment, one, two, three. So it's a segmental fracture. Three segments are there. More than one or two pieces, one, two, three pieces, it's a comminuted fracture. Comminuted fracture. So we can either have a simple transverse fracture, oblique fracture, spiral fracture, segmental fracture, or a comminuted fracture. So depending on the amount of injury, depending on the forces at the fracture site and the orientation of the fracture line to the bone, we can have all these types of fracture. So what is the mechanism of injury? So mechanism of injury varies depending on the age and the pathology of the bone. So most common is in osteoporotic patient, ground level fall may result in humerus fracture. Whereas in younger individual, high velocity injury in the form of motor vehicle accidents. Sometimes patient may have pathological fracture. We have done this class last pathological fracture. Pathological fracture is where there is some pathology which is eating away the bone like wood is eaten by the wood mites. So pathology. So it may be a cancer or metastasis, we can tell, or some primary bone pathology like bone tumors and all, or sometimes no burst injury. Burst injury means after I mean some explosive injuries and all, patient may have the fracture of the humerus. It may be open fracture with lot of comminution. So how is the clinical presentation? So patient will have history of trauma. There are signs of fracture in the form of pain, deformity, limited movements, and abnormal mobility. And as I told, radial nerve is in close relation at the spiral groove and also in close relation when it enters from the posterior to the anterior compartment. So these two levels, if there is a fracture, then patient is likely to have radial nerve involvement. So it present as, so if there is a humor here, if there a fracture, it may get entangled radial nerve, or when it comes anteriorly, these are the two levels where the radial nerve can get entangled inside the fracture and resulting in radial nerve palsy. It present as a wrist to drop and sensory distribution along the dorsal first ipses deficit. Then if there is a vascular injury in association, then patient will have vascular compromise. So how will you diagnose? So humerus fracture is very easy to diagnose. We do X-ray. So there is a rule of X-ray. It's hold goods for any type of fracture. So what are the rule of doing X-ray? So always include one joint above, one joint below. Include one joint above and below the fracture to know the fracture pattern. So because there is association of dislocation of the joints also, that's the reason we need to do it. Always include a joint above and a joint below when you are deciding the treatment. So don't accept the X-ray film without the joint above and below. Here, if you see there is elbow joint here, there is a humerus glenoid, humeroglenoid joint or shoulder joint here. So always you need to have a joint above and below. Then always take two views, AP and lateral. So don't judge the fracture or don't judge the injury only seeing on one X-ray. Most of the time, some X-ray won't be a fracture won't be appear only on one view. So always take two views, include two joints, one above and one below. When you are taking the X-ray for the injury to the limb. Then one few words about a specific type of injury that is run by name Holstein-Levin fracture. What is Holstein-Levin fracture? As I told you previously, when there is a fracture here at the lower third region, if you see, the radial nerve is coming out of the interosseous membrane and becoming the anterior compartment part. So at this level, the mobility of the radial nerve is very less because it is attached to the interosseous substance here, interosseous membrane. So any fracture here will pull the radial nerve inside the fracture fragment. And when you try to reduce it, it gets entangled and present as radial nerve palsy. So this is distal third humerus fracture where the radial nerve get entangled inside the fracture site. So patient finally result in radial nerve palsy. So this is name of this type of specific injury of involving the distal humerus is Holstein-Lewis fracture. Holstein-Lewis fracture. So what is Holstein-Lewis fracture? It's a fracture of humerus distal third region, and radial nerve is getting entangled. So it presents as radial nerve palsy. So this is Holstein-Lewis fracture. It's very important because many times it was asked in your PG entrance examination, the location of Holstein-Lewis fracture and the involvement of the type or nerve, which type of nerve is involved in Holstein-Lewis fracture. So with this, we'll move on to the next slide. What is the treatment? So what is the treatment of humerus fracture? So there is a humerus fracture can easily be managed with conservative method. So we can either use arm sling or use slab. So or hanging cast. Or last is functional cast bracing. All these methods doesn't involve any surgical intervention. So this is your hanging cast. This is your U slab. It is in the form of U, so it's called as U slab. Or this is called Sarmento brace. So these are the various methods by which we can manage the humerus fracture conservatively. So there is a saying here. What is the saying is, if you have a room and a humerus fracture patient here. So unless a patient is alone, it will unite. When the orthopedic surgeon enters into the room, then the complication results without touching the fracture. So humerus fractures most of the time readily unite without any complications. So if you feel like patient is going to have complications, then always you can go for surgery in the form of close reduction, IM nail, intramedullary nail, open reduction with plate and screw or external fixator. If you see here, we have fixed the fracture humerus with the interlocking nail, here with the plate. And if patient is having burst injury and open fracture, we can go for external fixation application. So now, what are the complications of humerus fracture? So malunion. Malunion is easily acceptable and readily acceptable. Why it is readily acceptable? Because we have lot of movement at the shoulder joint. So patient won't have any residual deficit or with minimal deformity without any functional deficit. So malunion is very much acceptable in humerus fracture. Whereas non-union. So what are the causes of non-union? As I told you before, 5I. 1, 2, 3, 4, 5. What is the 5I? One is inadequate reduction. We already dealt with that, but this is for only repetition. Then inadequate immobilization. Then inadequate vascularity or blood supply. Then infection. The last is interposition of soft tissue. So these are the reasons for patient developing non-union. So you can find all these things in case of humerus fracture where patient have non-union. So always remember the causes of non-union, 5 I's. Okay, then the last complication, as I told, entrapment of the radial nerve either in the radial groove or either in the Holstein-Lewis injury, patient will have radial nerve palsy. So radial nerve palsy. We'll read along for regarding radial nerve palsy. Radial nerve palsy. So there is a extensor deficit along with the involvement of this area, loss of sensation, sensory deficit. So this is all you need to know about the humerus fracture. So there are many more things, but it's out of your requirements. So I'll just end up my video here. Please like, subscribe, and share to my channel. Okay.